Welcome back to 90 Day Dental Day 29. So we're starting a brand new topic today for the next few days on oral surgery, and we've got none other than Sami Stagnall here to help us with it. We're kicking off today with assessment for oral surgery. Take it away, Sami.
Right, ladies and gentlemen, thank you so much for joining me. My name's Sami Stagnall. I'm a specialist oral surgeon based down on the south coast in England. I work with predominantly NHS referrals through intermediate minor oral surgery, but I'm also a private specialist as well, and I treat implantology patients. And anything from simple extractions right up to bone grafting, sinus lifts, etc. I'm really pleased to be joining you here for this video series regarding oral surgery. Now, this is something that gives people a lot of anxiety and that often causes people problems. Hopefully we can distill down in the few minutes that we've got to some key points. And in this first video, I want to talk to you about assessment, which for me forms the most important part of the oral surgery process. Taking the teeth out can sometimes be the simplest part of an overall treatment. But if we don't get the assessment right, we can't necessarily manage the patient correctly. And it all comes down to understanding that individual's history, their restorability of the tooth, the anxiety that comes with having the treatment out, and the radiographic assessments that are part of this. But what's last here on the list is actually possibly the most important, and it comes to thinking with the end in mind and understanding where it is we're heading towards in the long run. And if we can't understand where we're heading to, it's sometimes hard to understand the path that we've got to tread with this patient, and it makes it much harder to manage them along the way. So things that I like to consider when I'm starting out with assessing a patient is that you need to make sure that the treatment plan is still super important and a big part of your overall planning. Sorry, I'm going to do that again. You need to make sure that treatment planning is still very central to what it is that you're trying to do. Without planning, you are planning to fail. And that's a really important point to take home. And we mention it in lots of other aspects of dentistry, but we often forget that this is part of oral surgery as well. And that treatment planning is part of the consent process. And that consent process is continual. And unless you maintain good communication with the patient and help align them with your understanding of their treatment plan and your findings, it's going to be very difficult to keep them on board. And if you can't provide them with an appropriate understanding of their treatment and explain what the potential pitfalls or drawbacks or even complications may be, then anything you tell them afterwards is going to be an excuse rather than a warning, and it's an important part to consider. The first thing that I like to think about, and one of the most important things to discuss, is why is this tooth coming out? Often a patient is sat in front of us and they don't understand why that tooth is coming out. So understanding the rest of the treatment plan, if they're having more dental work, especially if you look in the mouth and see widespread caries, etc., is super important, because you want to know where you fit into that treatment plan. And if that patient is sitting in front of you to have a healthy tooth out so that they can have an easier way to open beer bottles, well, then this might not be the right thing by them. And you may want to revisit treatment plans with whoever the restorative dentist is, or actually revisit what their wishes and aspirations are so that consent is appropriate, and talk to that patient, understand what it is that motivates and drives them so that they have the right options and you've discussed everything with them. And again, it helps you anticipate complications, and so that everything you've discussed beforehand is a warning and it's not an excuse afterwards. Professional tennis players are very good at starting to plan their next shot before the ball has been hit on the other side of the net, rather than when the ball has bounced on their side. And it's an analogy I like to use a lot, because it's the mindset you want to start getting into, anticipating the complications and thinking ahead way before you have to manage it, so that if you do have to manage it, it's much simpler. Medical history taking is something that we've become quite good at now during COVID-19 and the lockdown. It's an important part of your dental assessment. We want to make sure that all systems are assessed properly. So go through question sets appropriately and talk to patients about them. Don't just gloss over it or let them sign a sheet out in the waiting room. You want to understand why they are saying what they are saying and how it's going to impact on you if they've had a heart attack in the last 6 months, if they get regular chest pains, are they going to be stable sat in your chair? Ask the questions and have the discussion, and if in doubt, take your time before you start treatment. Liaise with their medical physicians, understand them properly. Understand elements such as allergies, latex, antibiotics, things that you're going to put them in contact with that could have adverse outcomes. And are there true allergies? A lot of people claim to have allergies towards things like local anesthetics when those allergies are very rare. Talk to the patients, understand them, liaise with their medical practitioners if you have to. Understand, is that a healthy patient that is sitting in front of you, and are they appropriate for your treatment setting, or do they need to be referred to somewhere else? And ask the right questions around the patient for what they're telling you, but listen carefully to what they have to say and take it on board. Dental histories, again, are something that we've become very au fait with. And one of the things that's really crucial in dental histories is phobia and anxiety, and understanding why that patient is sat in front of you and why they behave a certain way. And a lot of the time, aggression is a manifestation of anxiety. So those really difficult to deal with patients are that way because they're scared of you, and threatening to take a tooth out adds to that fear and bolsters the way that they behave. So make sure that you understand, is local anesthetic the best treatment modality to treat them with, or do they need to go somewhere that can have other ways of handling them, such as with sedation or general anesthetic, but manage their behavior properly and be human, be understanding, understand them, listen to them and have conversations, because that's going to win your patient's trust, and it's going to have profound impact on your consent process and how you manage them throughout the course of their treatment. Crucially, if they have outstanding work, make sure that things that need to get done can get done. They might not need to wait until you take a tooth out for other things to be getting on, so they feel they're getting on with their journey. But you may be the pivot point in their new dental lives. If they have not gone to the dentist for a long period of time, you might be the first person they're seeing to take a tooth out. So get on with it. And if they've got pain, deal with it. Again, AAA is something that we have become very familiar with now during lockdown. Managing pain is something that all of us should be very comfortable with as dentists. Even if you can't take the tooth out, extirpate, get them out of pain, make sure that they're comfortable. Social history elements are something that we've become more comfortable discussing. But with oral surgery patients, other things that you might want to consider are they home alone? Is there someone who can look after them? If you're taking out teeth and they're on blood thinners, for example, are they going to be able to manage things if they are on their own? If they've had sedation or intend to have sedation, are they going to be able to have an escort who can take them back? These are all questions you need to figure out how to integrate into your assessment. And even if it's part of your documented written history forms, that's a great way to do it as well. If they have carers, if they're attending with family members, do they have capacities that are going to affect how you consent those patients? Understand your patients properly, and it helps form a much better picture and image of them. Now, when patients walk into the room, it's a great way to assess them straight off the bat. Are they walking and are they struggling to get in? Are they come in a wheelchair? Are they fit and healthy? That extra-oral exam starts as they're coming into the room, and as you're starting to see them for the first time of that treatment session. This patient in the picture here is Paul Michael Hughes, who is one of the largest mouths in the world. Now, as an oral surgeon, he would be great to treat because you could almost walk right in there and take out whatever tooth you needed to. But the reason I put this picture up is because we want to consider access when we're looking at extra-oral assessments. Is that mouth opening going to be a hindrance to us rather than a benefit? I think it is in this case. If it's a small aperture, well, if it's a tooth at the front, it may not matter, but if it's a tooth at the back, are you going to be able to make it in there with instruments to assess it or treat it properly? And can they lie back? If they're coming in wheelchairs, are they going to be able to transition from wheelchair to your dental chair? And do they have other musculoskeletal problems that is going to affect how they can lie down or position themselves in the chair? Remember, your positioning is important, and you have to do this job day in, day out. If you do damage to yourself stood in compromised positions, that may affect how you treat other patients as well. And think about your nurse and auxiliary staff. How are they going to help you as well? And this also has an impact on, for example, multiple visits. Are these patients going to be coming back several times? Do you need to schedule the work around their physical status to make sure that treatment is as comfortable for them as it is for you? When we graduate onto intraoral examinations, this is somewhere where people are obviously going to be more comfortable. But again, it's about strategizing and understanding the way in which you want to treat. So are you treating several teeth or simply just one or two teeth? And how are you going to get to those teeth? If the tooth is broken down, are your instruments going to fit over those teeth or those roots? And do you have the instruments that you need to tackle those teeth? And again, the position of the tooth, whether it's impacted or angulated, may have an impact on how you stand and approach that tooth during the surgery. And checking suitability of the tooth is super important, because we want to know that the indication for removal is absolutely correct. And when we're considering other factors of taking that tooth out, we have to consider the teeth and the structures around that tooth. So are there restorations in these heavily restored patients and these older patients that we're starting to see? Are we going to do damage to crowns, bridge work, other structures that could be affected as a result of us elevating teeth out? And what are we leaving there afterwards? In the case of some of these wisdom teeth, which are impacted, but there's great big bony defects, are you leaving recession, mobility, sensitivity? And are these things that the patient needs to know about beforehand so that they're fully aware and consented? And impacted teeth, they may be near adjacent structures, and how are you going to get to them? Especially with submerged teeth, sometimes we see this with deciduous retained teeth. They're in compromised positions, and that may affect how we can get to them properly too. We want to consider all the right indications and all the right reasons for taking a tooth out, and some of those are more obvious than others. There are obviously guidelines out there that help us predominantly with things like wisdom teeth, which we're going to discuss in another episode. But explain and talk to your patients about guidelines if they do or they don't fit them, as it's an important part of their understanding and the process of having them on board. If you're not going to stick to nice guidelines for whatever reason, then explain that to patients and document it properly. They are guidelines, they're not standards, so you don't have to absolutely live by them, but it's important to make sure you explain your own professional justification as to why you're swaying away from what might be considered a professional standard. Finally, the thing that we get onto at the end of all of this is radiological assessment. And it's important to consider what it is that we want to see. What is it that is going to necessarily change our treatment plan? And that might drive the type of imaging we need. We're bound by the rules of IRMA, and with that, ALARP, so as low as reasonably possible. If you don't need to take a cone beam, then don't take a cone beam, unless it's going to change how you manage that patient physically in the chair. And also that may impact on the consent process. But irradiating patients unnecessarily is not called for, and we've got to make sure that we do best by we need to do right by the patient. So pick the right imaging so that it fits what it is you're trying to understand. And from this, make sure you report your images appropriately, and that will help you decide on the rest of your treatment plan. And explain these images to patients, discuss them, show them, explain, because it will bring people on board with your understanding and explanations and help them see where you're coming from. I put a couple of points there about wisdom teeth, and again, this is something we're going to touch on later, but when it impacts on adjacent anatomical structures, it's important to make sure that these are represented to patients properly and that they understand what it is that you're trying to achieve. So hopefully we've covered a few things there that are important to assessment, and you start to think about how you look at your patients when they're coming in for oral surgery assessments or as part of your regular full restorative workups. If you're struggling with oral surgery, make sure you find a local mentor, speak to your local maxillofacial surgeons or specialist oral surgeons, find someone who can come and help you and talk through cases, and it'll definitely improve your assessment in the long run. I'm looking forward to seeing you for the next couple of episodes. Get in touch if you have any questions. Thanks, guys.
Comprehensive and a great start. Join us back tomorrow for part 2.